Assalamu alaikum. Today's our topic is urolithiasis. Definition. Urolithiasis is calculus formation at any level in the urinary collecting system, but most often the calculi arise in the kidney. Types and causes of stones. 1. Co-oxalate and co-phosphate stones, 80%, etiology. 150% are associated idiopathic hypercalciuria. Without hypercalcemia, most in this group absorb calcium from the gut in excessive amounts and promptly excrete it in the urine, to 10% being caused by hypercalcemia with hypercalciuria present in primary hyperparathyroidism most common. 1. Vit-D ingestion, Vit-D intoxication. Co-oxalate and phosphate stones cont. 3.5% are because of hyperoxaluria, which may be because of diet rich in oxalate present in green vegetables gives hyperoxaluria. T. Gut disorders like Crohn's disease. 4.20% are because of hyperuricasuria. 5.15% to 20% gives no known metabolic abnormality referred to as idiopathic calcium stone. 2. Triple phosphate stones, 15%. Magnesium, ammonium, and calcium phosphate stones, struvite stones, magnesium-containing mineral found in kidney stones associated with bacteria, are formed largely after infections by urea-splitting bacteria. For example, Proteus vulgaris and some Staphylococci that convert urea to ammonia. The resultant alkaline urine causes precipitation of magnesium ammonium phosphate salts. These form some of the largest stones, Stackhorn calculi. Uric acid stones, 5 to 10%. Uric acid stones are common in individuals with hyperuricemia, such as patients with gout, and diseases involving rapid cell turnover, such as the leukemias gives 1 uric acid level in urine. However, more than half of all patients with uric acid calculi have neither hyperuricemia nor increased urinary excretion of uric acid. In this group, it is thought that a tendency to excrete urine, a pH below 5.5, may predispose to uric acid stones. For cystin stones, 1 to 2%. Cystin stones are caused by genetic defects in the renal reabsorption of amino acids, including cystin, leading to cystinuria. These stones also form at low urinary pH. Clinical features may be asymptomatic. Severe renal colic, flank pain, or ureteric colic. Colicky pain in lumbar region radiating down to inguinal region, hematuria. Ureteric or urethral obstruction, URI. Complications, obstruction. Hydroureter, hydronephrosis, stasis, and infection UTI. Compression atrophy gives acute or chronic of kidney. Renal failure, squamous metaplasia, squamous cell carcinoma, hydroureter. Clinical diagnosis, history, location, and severity of the pain, which is typically colicky in nature, comes and goes in spasmodic waves. Pain in the back occurs when calculi produce an obstruction in the kidney. Physical examination. Fever and tenderness of costovertebral angle on the affected side. Imaging studies, X-ray KUB, ultrasound, CT. Urinalysis, which may show RBCs, WBCs. Bacteria, urinary casts and crystals, urine culture, sensitivity. To identify any infecting organisms present in the urinary tract and to determine the susceptibility of these organisms to specific antibiotics, CBC, for neutrophilia, suggestive of bacterial infection, as seen in the setting of struvite stones. Renal function tests, 24-hour urine collection to measure total daily urinary volume.